Well, the management for castration-sensitive metastatic prostate cancer patients has drastically changed over the last 4 years now. Traditionally, what we do, we actually block patient testosterone, which has been the standard of care since the 40s for that matter. And oftentimes what happened back in the days is once men progress from suppression of testosterone, we used to use sequential therapy, whether it's chemotherapy or oral therapy, novel agents and so forth. So what we've been doing over the last 4 years is trying to bring those agents at front because biologically it doesn't make a lot of sense for us to wait for people to become resistant. So we did that, and there are two pivotal trials in 2015 that were published, one from the British system called Stampede, and the other one from the American system called the ECOG 3805 or Charted data, basically addressing the question of the role of systemic docetaxel-based chemotherapy as a frontline treatment for our patients. So in those two trials, basically what we did is quite simple. We actually asked the question, if we were to add docetaxel-based chemotherapy to the suppression of testosterone, who lives the longest? And what we did, we were able to demonstrate that patients who get docetaxel-based at front actually have a significant survival improvement compared to those men who only get suppression of testosterone, what we call ADT. Now, important as well is that our American data did demonstrate that benefit primarily in patients with high volume disease. So now I think fundamentally what I think of prostate cancer patients, fundamentally I look at volume of disease, which is defined by where is your disease located and how many lesions you have. The American data look at very specific definition for high volume disease, which included the presence of visceral metastases, meaning lung or liver disease, and the presence of bony metastases, but specifically having more than 4 bone lesions, and one of those had to be outside the spine, if you will. So that data in 2015, along with the British system called the Stampede data, actually solidified the role of docetaxel-based chemotherapy for those patients. What changed in 2017 was the French data called LATITUDE, which is a data that actually look at the addition of abiraterone acetate, which is an oral CYP17 inhibitor, an agent capable of actually disrupting specific enzymes in the adrenal gland that are thought to be important when people become castration resistant. So the LATITUDE was specifically designed for patients with high volume disease, with metastatic disease, and patients were randomized to receive ADT, the suppression of testosterone, plus abiraterone acetate and prednisone against ADT plus placebo. High volume disease in the French data was defined a bit different than the American data. It was defined by you having 2 out of 3 adverse features: Gleason score of 8, 9, or 10, the presence of more than 3 bone lesions independent where those lesions were located, and also the presence of visceral disease. So if you have 2 out of those 3, you were a high volume and you were able to enroll on trial. That trial, similar to the Stampede and similar to the Charted data, were powered for survival benefit, and drastically we saw significant improvement in outcome for those men who received ADT in combination with abiraterone acetate. So the hazard ratio, which is the relative risk reduction or mortality in these trials, is almost 0.6, which means you can actually tell a patient that if you get the combination of what we call intensification of your therapy with ADT and ABI, or for that matter in the Charted data and Stampede with ADT and chemotherapy, you can almost reduce the risk of death by almost 40% when you intensify the therapy. So now, also Stampede, which is the British system, also look at the addition of abiraterone for their metastatic patient population, and yet again, a significant improvement in outcome for those patients with metastatic disease. So I think what has happened in the last 4 years since 2015 is we have reshaped how we manage men with metastatic disease. Again, people who have never seen ADT before or suppression of testosterone. So I would argue that the summary of this is that men with metastatic disease one should divide their volume. If you have high volume disease, the standard of care is either to get ADT plus 6 cycles of docetaxel-based chemotherapy at the standard dose, 75 milligrams per meter squared times 6 cycles, followed by ADT, or if you follow the Stampede and or the LATITUDE data, to give those men ADT and abiraterone acetate, which are the oral agent. Now, that's for high volume patients. Now, for low volume patients, okay, the standard of care, in my opinion, based upon the British data, the Stampede data, is to offer them ADT and abiraterone acetate. Now, what is a bit different for those low volume patients is the British data also has very compelling data suggesting that patients who have their primary prostate in place and yet have metastatic disease and are fit within that low volume group of patients, not only should they receive ADT and abiraterone acetate, but also one should consider radiating their primary tumor, because that is the subset of patients in that data that clearly demonstrate a survival improvement when you do ADT, ABI, and you radiate the primary tumor. Now, it's a bit different because the data for radiation therapy use, for that matter, chemotherapy in the STAMPEDE data. But we are extrapolating that data because we believe ADT chemo may be in fact similar for those patients who get ADT and abiraterone acetate. So that to me has been the drastic difference over the last 4 years, which has really reshaped how we manage these patients. So really, a patient with metastatic prostate cancer should not be receiving ADT alone, should actually be intensified to either ADT chemo, ADT ABI for high volume, or ADT ABI and maybe primary radiation therapy to a prostate tumor for low volume disease.